presentation, zoom into some panel discussions. Let's take for the first presentation, ladies and gentlemen, on financing universal healthcare and health security in Africa, an assertive, practical, and substantive agenda to catalyze meaningful change in advancing UHC and promoting health security. The acting head of the health financing at the World Health Organization headquarters, Mr. Matthew Jowerts. Dr. Matthew Jowerts. A round of applause as he comes. It will be remiss of me, however, not to acknowledge the plenary chair, ladies and gentlemen. He will set the tone for this presentation by walking us, oh sir, please. Okay. On achieving universal healthcare coverage and promoting health security in Africa. Make welcome Dr. Anefi Asamoah Bah. I guess in his absence, we can shoot straight into the presentation. Over to you, sir.
Good morning, everyone. I think that cocoa must be pretty good, actually. That's what I'm thinking. I didn't try it myself, maybe later. Okay. So it's a real pleasure and a privilege to be here with you today. I think Honourable Minister has left, but Honourable Minister, Excellencies, delegates. My name is Matthew Jowerts. I am based in WHO headquarters in Geneva. And I work on the health financing team there. So my work kind of looks globally at a lot of trends about what works, what doesn't work in health financing for UHC. As a specialized technical agency, this will be a fairly technical presentation, but I think the people in the room will, I think, should be able to cope with that. If not, then please shout if you don't understand something that I'm talking about, or come and get me later after the presentation. Okay, so let's see if this pointer works. We had some pointer issues, and now it's not working. Okay, so we did a lot of testing beforehand. So just give me 1 second. Okay, great. It's a little bit twitchy. Let's see how we go. Great, so I'm just going to say a little bit about the challenges ahead, and I'm going to have to stand sideways to look a little bit at my own slides. The challenges ahead for health systems in Africa, clearly, with this whole UHC perspective, which drives all of our work. And then I'm going to hark back a little bit to the 2010 health report, which was organized in two sort of broad themes. One about getting more money for health, in particular public money for health. And given the audience and the focus of this event, I'm going to ask that question a little bit, what health insurance can contribute to raising more public money for health. And then we flip it around and we talk about getting more health for the money, and similarly I'll not only talk about health insurance, but we'll reflect a little bit on how health insurance can help health systems get more health for the money. And then I'm going to end with, I guess, a call in a way for greater coherence across health systems. And I'll talk a little bit more about that. But I think when I reflect on the work that I do and the team globally, a lot of it is helping. We've seen a lot of growing fragmentation and complexity in health systems, a lot of innovation. But often what we're left with now, what countries are dealing with, is quite fragmented health systems. And a lot of our work is trying to actually put some of the pieces back together in a coherent format. So I'll reflect a little bit on that. So where is the African region now? So, okay, what do we have here? So I'm assuming that you all know about the SDG goals. Goal 3, for universal health coverage, we have 2 indicators. The first one about service coverage, so are people getting access and using the services that they need? That's an index 0 to 100, and that runs along the top. More health service coverage is better. The second one is on financial protection, elevated with equal status, right? And it's worth noting that, and it's, I suppose, only the last decade or so, maybe a little bit more, that the evidence about financial protection in health systems has really grown. And I think it goes without saying that we don't want health systems to impoverish patients in the process of getting the care they need. The links between income and health and so on goes without saying. So it's also a fundamental objective of health systems, not only to improve health, but also to ensure financial protection. And we map that on the left-hand side. So it's kind of an inverted scale. So if you're moving upwards, it's better. That means there's less financial protection. More and more we project these two indicators simultaneously. You sometimes see one in isolation of the other, but it's really important that we put the two together. So what do we have here? This is a short time series for Africa. The latest data that we have where we can have both indicators is 2019, which is an issue, right? It's a big issue, the recency of data, particularly on financial protection. But broadly speaking, what we've seen there since the year 2000 is some movement from left to right, which is improving service coverage, and WR made reference to that earlier. And financial protection, yeah, I mean, the last couple of years dipped down a little bit, hovering around 7-8% on average for the countries in the continent. If we just put this in context quickly, these are WHO regions, right? So the Eastern Mediterranean region, further to the right, higher service coverage on average, but worse financial protection. If we go to the Americas, up in that top right-hand part, Southeast Asia, again, a downward trend, right? And then similarly, when we put on there the Western Pacific, which includes China, this is population weighted for those that might have asked. So that drives a lot of what we see there. Huge downward slope there, which is essentially saying that big increase in people using services, but doing it largely fueled through out of pocket and worsening financial protection as a result. Where we need the world to go is basically towards that top right-hand corner. The recent progress on service coverage, hopefully you can see that. There's a little bit of a cut-off from the screen there, but the recent progress in service coverage in the African region has been driven principally by improvements in tackling communicable diseases. So this service coverage index, it is not perfect. There are a bunch of sub-indexes, but the one which has really driven overall progress has been in tackling communicable diseases. Now, the health challenge going forward, I don't need to tell you this, but I'm going to tell you anyway, is this growing burden of non-communicable diseases, huge surge. It's a little bit small, the text, but let me just read it quickly. There's been a huge surge in the burden of NCDs in sub-Saharan Africa over the past 2 decades, increasing incidence of cardiovascular risk factors, unhealthy diets, reduced hypertension, etc., etc. NCDs are set to overtake communicable, maternal, neonatal, and nutritional diseases combined as the leading cause of mortality in sub-Saharan Africa by 2030. Okay, now, what does this mean for health systems? This isn't really my area, but it's important when we talk about health financing. Ultimately, financing is there to serve service delivery, right? So that has to guide all our sort of thinking in health financing. So WHO recently released at the last World Health Assembly this essential package of NCD disease interventions. I'm not going to read through these, but these are the types of services that need to be ramped up and delivered, not only in the African region, but absolutely in the African region. In this document, there's a set of minimum interventions defined through which NCDs can be managed at the primary care level. And he mentioned this is feasible even in low resource settings. Now, I'm not a service delivery expert, I'm not a medical doctor, but a lot of you in the room might be thinking, what does this mean for the way we spend our money now, for the types of services that we're delivering? And what are the shifts that we need to see if we're going to get ahead of the game on this? We know what's coming down the road, okay? Now, what's not captured in that overall service coverage index is some sense of inequalities. We don't get great data systematically on inequalities. This chart on the right is from the recently released Global Monitoring Report, which is the joint World Bank WHO publication. And this data is for 70 to 80 countries. And it gives us a sense of, I mean, it's no surprise that there are inequalities in access. This is specifically for RMNCH services, from DHS surveys and MICS. We tend to be very reliant on those surveys for whatever data we have. And essentially, dare I try and use a pointer? I don't want to blow up. Oh, I knew I'd blow it up. Okay. All right. I'm not going to try and do the pointer, but basically, if you look at the left-hand side, economic quintiles, and there's some helpful median points there, and it's not surprising, okay? The poorest quintile, utilization of RMNCH services is lower, and it increases with income. You see a similar with a relationship, higher education, leading to higher utilization, and some urban-rural difference as well. Now, this is important, right? Because unless we also address inequalities in access, it's really going to put a brake on how much we can shift that overall service coverage index. So inequalities is a fundamental part of the agenda as well. So on the financial protection data, this is from a forthcoming report. It's a very pretty chart. I'm not sure how useful it is. But basically for SDG 3.8.2, sorry, I don't know if you can read it, sorry. But basically this pulls data on levels of catastrophic spending at the 10% threshold level. And it's color-coded by upper middle income, lower middle income. So in a quick summary, what we see there is that, there you go. 5 countries had incidents of catastrophic spending much higher than the rest of the group. You can see the list there. And 2 countries actually doing very well, Gambia and Zambia. Zambia is an interesting one. We might come back to Zambia. It's shown massive progress in the last 2 decades, WR and another Delhi. Massive progress in the last 2 decades on service coverage and incredibly on financial protection. And I might add prior to the introduction of health insurance. But that could maybe lead us to some interesting debate later on. Okay, so very much part of the agenda there. What's driving poor financial protection? So here's some data which breaks down from a selection of countries the composition of out-of-pocket payments. So, I don't know if you can see the label at the blue does dominate. The blue is spending on medicines. This is a huge issue globally. So, you know, that is a theme for most countries. But the picture is different in different countries, right? In some countries, it's not Senegal. It's not the medicines that's really driving out of pocket. And so I think understanding these drivers is something that clearly has to be done locally. We can't just make assumptions that it's medicines. We need detailed information on where are those drivers of out-of-pocket spending. And then from that, we can work out some policy responses. So medicines is a big issue. That medicines agenda, again, I'm putting forward maybe one something that explains it to some extent, but again, local information, local analysis is critical. But, you know, outpatient medicines seems to be a driver closely linked to this growth in the NCD burden that I've already mentioned. The need for lifelong medication, daily medication. We often think of poor financial protection being driven by those, let's say, low volume, maybe more rare events, but very high cost, be it cancers or a road traffic need for intensive care. But increasingly, the evidence is showing it's more than that actually at the system level. At the system level, it's high volume, relatively low cost expenditures that's actually the problem. So that's something we have to get on top of if we want to move to that top right-hand corner that I mentioned earlier. I mentioned medicines there. There are other factors. You know, there's no magic bullets. I mean, one could say, well, add medicines to the benefit package, that might go some way. But, you know, we also need to reflect a little bit on some of the broader forces going on, how patterns of utilization are maybe shifting between public-private sectors, for example. So we need to sort of reflect. There's like to be a broad set of factors that will explain the patterns observed, and hence will dictate the policy responses that need to be put in place. So a quick summary of the challenge ahead for the African region to move in that direction. There needs to be continued increases in service coverage, in particular addressing growing NCDs, at the same time addressing inequities in use. I mentioned in particular income-based, but it's clearly not only that. Improving, it's a difficult agenda, right? But at least we know what the challenge is. Improving financial protection at the same time. And I think, as Tedros said in his opening remarks, you know, strengthening PHC is going to be central to this agenda. I mean, there's a lot of debates about PHC, but I think deep down we all know fundamentally, you know, prevention, highly cost-effective interventions, early detection, treatment. It's not only, I think, is an obligation from a sort of human point of view to prevent disease, but, you know, if you're looking at the costs to the health system, there's really no debate on the importance of that. Now, in WHO, the way we think about health financing, just quickly, it follows what we call a functional approach. So I can't move away from the microphone here, but on the left-hand side of the diagram, in the red, we think of health financing in terms of these blocks. And these are functions, and these are functions which all health systems play. High income, middle income, low income, whether you call it social health insurance or whether you call it NHS or tax, but it doesn't matter. They all play these common functions. Revenue raising, pooling, purchasing, and then some definition of benefits that are purchased. So deliberately, we use this framework to move away from the labels of tax-based and health insurance. So you don't see the words health insurance, excuse me, on that framework. You know, insurance is essentially a risk-sharing function, and that takes place through the pooling of resources. So that's handled in the pooling. Tax-based systems provide insurance for their citizens, right? We don't tend to call it that, but they're effectively providing the insurance function, and very effectively so in many cases. Now, those four blocks, if you like, that's the way we approach health financing policy. This is where policy takes place, and by improving policy around these functions, we would hope to see improvements in health system performance, be it efficiency, equity, and then ultimately feeding into our SDG indicators. Now, we recently developed this assessment called the Health Financing Progress Matrix, and the idea there was to try and condense and synthesize our knowledge the last 20 years or more into a set of what we call desirable attributes of health financing systems. What does a high-performing health financing system look like? And these have, I don't expect you to read all those, I'll come back to them in subsequent slides or selected ones. Really a set of signposts that we sort of try to lay out. We don't say that these are perfect. We hope that it adds something to the dialogue in terms of bringing greater clarity and trying to crystallize, you know, a huge volume of information, be it theoretical, conceptual, empirical, and so on that's out there. Okay, so let me keep going if I can. I think my tab has stopped working. Oh, here we go. It's come back. All right, so let's think a little bit about more money for health, in particular, more public money for health, and at the same time think about whether health insurance can help. So one of the desirable attributes that we're there on revenue raising, and this is sort of a positive statement which is a feature of a high-performing health financing system, is that health expenditure is predominantly based on public or compulsory funding sources. I think everyone knows that. That's why we talk about reducing out of pocket. It's the flip side of the same thing. Now, I wanted to share, in light of this, some analysis that I did with colleagues. It's a few years ago now. It's some data and development analysis. And we looked at the relationship between how much countries spent, public spending on health per capita. We used a PPP along the x-axis there, the horizontal axis. And we wanted to look at levels of spending and compare it with how those countries were performing on those two UHC indicators. So this is the service coverage indicator. So basically what you see there is, yes, as spending goes up, no surprising, service coverage goes up. What is very interesting is the huge variation you see, especially below $100, for example. Huge variation in how countries are performing, despite spending similar amounts. But it plateaus as you get to around $200 per capita. There's some, if you like, some sort of plateauing off. Now, when we look at financial protection, and we did this in terms of the public as a share of total, because for data issues, these are the red ones. A very different picture, and basically what you see is even at fairly high levels of spending, a huge dispersion. It seems to be much more of a challenge. You know, delivering the services, maybe just getting enough inputs, right? Enough doctors, nurses, facilities, supplies, and so on will drive that service coverage. Financial protection seems to be a trickier business, right? So that's the first point. So in summary from that, and this speaks to a slightly different agenda, but we often get asked in WHO, how much should we spend on health, right? And, you know, when we try and be clever, right, clever technical people say, oh, there's no magic number, right? You know, there is no magic number. And that previous slide tries to illustrate that you could pick $50 per capita. The performance varies wildly. Now, there may be a lot of non-health system factors that drive that, but probably some health system factors as well. And we do see good performance happening at low spending levels and vice versa. So we bear that in mind because, yes, it is about how much money we spend, but it's not only about how much money we spend. That's the more health for the money part of the presentation to come. Now, what about social health insurance? What can it offer? So when countries launch into social health insurance, typically what this means is the introduction of a new payroll tax, right, as a health insurance contribution. Now, there's a bunch of issues that flow from this that countries have to grapple with. The first thing to say is this does represent public money, right? Our sort of criteria for that are that these revenues are mandatory, prepaid, and pooled. And so that criteria is met. But there's a lot of issues, and I'm not going to go into them all now, about what is the rate, the contribution rate. Some countries even get stuck on that for years, right? What rate to charge at? Do both employees and employees contribute? How broad is the tax base, right? This is a major issue, right? That if your economy is largely operating in the informal sector, you've got a very narrow tax base on which you're drawing. Are most salaried workers actually in the public sector? In which case, is this really new money? Because it's essentially coming from general budget funds anyway. There's an additional question that this represents an earmark tax, and there is experience from some countries that unless health negotiates really strongly with finance, that finance might just reduce discretionary allocations, right? So, well, now you're getting your dedicated source. So, you know, what we're interested in is actually the total level of public financing for health. A sixth issue there, what's the new social contract that comes with this tax, right? Those that are paying, what are they expecting? And I think, you know, in the technical community anyway, there's a lot of concern that this is a shift towards contributory-based entitlements, and that can raise some equity concerns in health systems. And finally, you know, new money, great, but where is this new money flowing? Is it actually flowing to the priority services and groups that I outlined at the beginning of the presentation? Those concerns of a two-tier system and greater inequalities growing, a lot of countries have responded to this, right? So acknowledgement that there needs to be subsidized contributions for the poor, and I'd say even for the near poor. But even once you've covered the poor, there's serious challenges collecting contributions from the, let's say, the non-poor informal sector, which often comprises the majority of the population. And then what we see is in many countries, lower and middle income countries, that have this kind of an approach or a SHI system, you have this, what we call a missing middle. You cover the salaried, you cover the poor, but you've still got, could be 50, 60, 70% of the population. It's really difficult to collect from that. So where does that leave us, right? What's the strategy here? What this means is at the end of the day that even countries that go down this route, they still rely heavily on budget transfers, right? If you want to increase that contribution rate in that model. And I understand, but I'm happy to be stand corrected that in Ghana, around 3/4 of NHI revenues are from general budget transfers. And what we do see is that most public spending in countries, lower middle income countries, it still flows through the budget. So these charts here are from our 2019 health expenditure report. If you look on the right-hand side, this is basically health spending. The orange represents health spending through SHI schemes, and the blue essentially through the health budget. And you've got low income, lower middle income. Even if you go to high income, the majority of spending, public spending, still takes place through the budget. And you can see the situation for low and lower middle income countries. So yeah, it adds a little bit of money, but the vast majority of funding still flows through the budget. Sorry? All right, I've got a 3-minute warning. Sorry about that. Okay. Do I have half an hour? That would make, I'll better stop talking. That would make 5 minutes. So. Okay, so more health for the money. What can health insurance contribute? So some of our desirable attributes here: resource allocation to providers reflects population health needs, also reflects how well they perform. Purchasing arrangements are tailored in support of service delivery objectives, and also ensure some kind of budgetary control. A quick reminder that increased public spending does not automatically translate into UHC progress. We see that on the chart there. And I was reminded, putting this together, of a paper done by colleagues of mine at the University of York. It's 20 years ago now, it's like 25 years ago, where they were reflecting on this wave of introduction of social health insurance in newly independent states after the breakdown of the Soviet Union, right? And there was a lot of curiosity because there was a sense with economic collapse which happens there. There was this initial idea that this was a way to raise more money. But there was an additional motivation, which was greater autonomy over spending, taking money out of the budgetary system to actually be able to spend it more effectively. And that's the question that I think we're all faced with. Will spending more and more of the dollars through social health insurance help to drive progress towards UHC? Well, what do we need? To answer that question, I just refer back to what we said earlier. To move there, we need to continue to increase service coverage, address NCDs, address inequities in service use, improve financial protection, especially for the most vulnerable and those with greatest needs. And PHC has got to be a fundamental part of this. So, will shifting more dollars to SHI address those questions? That's the perspective that someone like myself would take looking at the whole health system picture. Now, social health insurance agencies can drive improved spending, absolutely. They can have a much more laser focus on provider performance and quality of care. I think there's you saw the presentations earlier, a lot of dynamism that comes right from the agency, absolutely. Greater flexibility to pay providers in new ways, to adapt and change the way that they pay, maybe to engage private providers, often much better information systems, maybe quicker to introduce health technology assessment processes. So I think that is often what we see. It is worth noting that you can do a lot of these things without a payroll tax, right? And there are countries that have introduced a dedicated purchasing agency, but fully tax funded, right? So these two things do not have to go together. Right, I'm going to speed up a little bit. But we also need to focus on spending health budgets more effectively. You know, that reminder that they still represent the vast majority of spending. I'm feeling slightly stressed on time. So just to say, this is a comparison of two countries that spent the same amount per capita public, Malawi and Sudan. Malawi outperformed on these specific indicators, Sudan on all those indicators. Sudan's had health insurance since 1995. Malawi has not, but it has done a lot of work to focus its spending on an essential package and to really sort of focus its attention in delivering that essential package. So there's many ways to skin a cat. It's not what you do, it's how you do it, etc., etc. Okay, I have a last couple of slides and then I'm absolutely done. On spending budgets more effectively, there's a lot of interest. There's a big agenda around this at the moment. We call it PFM and health financing. Some of you might be coming to Montreux for a big meeting we have, focusing on how budgets are formulated, reflecting health priorities in budget formulation, not just health facilities, right? Getting money to flow to where those priorities. That's not easy. There's a lot of work going on that, also on budget execution and reporting. And just a quick note, it is possible that spending can get worse under health insurance. The great Adam Wagstaff, who is no longer with us sadly, I love this paper he put out about China, which basically showed that after introducing health insurance schemes, financial protection got worse, right? So there was this sudden growth in consumption of, if you like, uncontrolled, high-end care. And providers, importantly, had this incentive to maximize their revenues because they could keep it. You put that together, it was a bit of a disaster. I recently did some work with one of the provinces in Pakistan, which has a new fund, fully budget-funded, tax-funded, fund social protection health scheme. I forget the name exactly. It just covers inpatient care. Within a couple of years, they are scared stiff. They're saying it's not sustainable. Dialysis is knocking, the dialysis care is knocking over our fund. Not surprisingly, they have an open-ended payment mechanism. You know, you can have a health insurance but spend badly, right? But you know, the solution to that problem, that particular problem, yes, they need to fix their payment mechanism. But actually the solution there sits outside the health insurance fund. What's going on at the primary care level? Right, and I think this is the coherence point I wanted to make, that this particular fund is operating in isolation from the rest of the health system and it's really not connecting with what's going on there. And I just finish with this, I guess this call for more coherence within health systems. I'm not going to dwell too long on this, but I presented something recently at the International Health Economics Association conference. It's a meta-analysis of 25 country assessments. Basically, the top line is on the top there, that greater fragmentation in health systems, multiple schemes with different benefit packages, really not pulling together as one system. It was highly correlated with poor performance on financial protection. And as I said, this is quite a big agenda for us in our work. So this is my last slide. I'm not going to read through it all, because it's really just a recap, but hopefully the presentation can be shared. But I think the challenge ahead of us is clear. We have a lot of knowledge about what's coming. We have a lot of knowledge about what works. Joe Cutzin, who recently retired from WHO, he used to say, it's okay to make mistakes, but don't repeat the same mistake or don't repeat old ones. And I think it's really important that, I mean, that's why events like this can be so important, that we share knowledge about what works and what doesn't. So thank you very much. Thanks. Where do you want me?
One more time, ladies and gentlemen, a round of applause for Dr. Matthew Jowett. We're joined now by our chairperson for this plenary, ladies and gentlemen, Professor Yaw Edudjemfi. A round of applause for him. Thank you for joining us, sir. He'll be sharing his thoughts with us at the end of this plenary. We shall now move to the second presentation. We have lessons on health innovation in Africa. To do that presentation, ladies and gentlemen, welcome from Kemri Wellcome Trust. From Kema, Professor Edwin Barasa. I hope they got the designations correctly.
Yeah, it's health insurance. It doesn't matter. It's fine. So good morning, good afternoon, everyone. My name is Edwin Barasa. I work for the Kemri Wellcome Trust Research Program in Nairobi, Kenya. And I'm going to have a very brief, hopefully, have a brief discussion around the experience of health insurance in Africa and lessons that, we can take from this experience. So like Matt, I'm trying to get this to work. Okay. Okay, great. I think everything is working now. So as I mentioned, I'm going to have a very brief discussion around some of the key lessons that we've gotten from some work we've done looking at health insurance in Africa. So I'm going to talk about two key things. One, reflect on the findings and lessons from this work. And second, think beyond the findings from this work and ask ourselves what lessons can we learn from countries that appear to be either exemplars or outliers with regards to health insurance in low and middle income countries. So, the fact that we are all here is evident to, gives a lot of credence to this statement. The fact that many African countries are either implementing or thinking about implementing health insurance schemes as a mechanism for financing their health sector, but they are doing this against a specific context. One is the fact that the African continent is mostly low and middle income. It has a very high level of labor informality. So on average, about 80% of labor in Africa is informal. And then of course, there's also a high incidence of poverty. So on average, over 40% of the population in Africa lives below the poverty line. So this is important context against which we need to consider the fact that African countries are increasingly adopting contributory health insurance as a mechanism for financing the health sector and anchoring their universal health coverage aspiration to this particular mechanism. So some years back, this is in 2001, we did some work to try and understand, the performance of health insurance as a financing mechanism in Africa. And we used secondary data from the demographic and health surveys, which I'm sure you're all familiar with. And we managed to get data from 36 African countries using their latest demographic and health surveillance surveys. So what did we find from this analysis? We set out, number one, to look at what is the level of health insurance, what is the level of population enrollment to any form of health insurance across each of these countries. What is the level of enrollment in any form of health insurance across these countries, and for specific forms, because the types of health insurance mechanisms within these countries varies depending on the country. So some countries have public health insurance schemes, some countries have mostly private health insurance scheme. So one of the things we set out to look at is what is the progress, or what is the performance in terms of achieving population coverage. The next thing we looked at is what is the level or extent of equity in coverage with health insurance across these countries. And what we found across the countries is that generally the level of health insurance across African countries was really quite low. So on average, the pooled mean was about 8% in countries that had some form of health insurance, and these ranged quite a bit. Very few countries had a level of health insurance that one would say is reasonable. So only 4 countries we had to use a much lower threshold of reasonableness, as you can imagine. So only 4 countries out of the 36 countries had population coverage with health insurance of above 20%, and only 2 countries had health insurance enrollment of above 50%. And for those of you that are Ghanaians, you'd be happy to know that your country is one of the countries that is an outlier. That your country is one of the outliers with regards to good performance in trying to get the population enrolled to a health insurance scheme. So the outliers in Africa were really Ghana and Rwanda, and to some extent Gabon. So with regards to the level of coverage, as you've seen previously, the level of coverage is generally quite low, but we have some outliers, but generally quite low. Now, when we looked at inequalities, so looking at what is the distribution of health insurance coverage across socioeconomic status, across socioeconomic quintiles, the picture that we get is this, which is the fact that health insurance coverage in Africa is generally quite inequitable. So most of the people that are enrolled to health insurance schemes across African countries are on the richer side of the socioeconomic scale. For those of you that are familiar with these are what we call concentration curves. And essentially what it means is that if the distribution of health insurance or enrollment in health insurance is equal or equitable, then those curves are supposed to lie on the diagonal line, so on the 45-degree line. So if you have equality, you expect those curves to lie on the 45-degree line. If there is a deviation from the 45-degree line, it means that you have inequality. The farther away you are from the line, the more unequal you are in terms of the distribution of health insurance. So you don't need to read anything. The only thing you need to see is that most of the lines or the curves are far away from the line of equality. So that tells you that health insurance coverage in Africa is quite inequitable. And if we zoom into one of them, again, you can see that for almost all the countries, you have high inequality with regards to health insurance coverage in the African continent. But again, so one way to assess inequalities is to look at the concentration curves, which you've just shown. The other way is a very simple math, which is to look at the proportion of people that are covered in the highest quintile, so the richest people, divided by the proportion of people that are covered in the lowest quintile, which are the poorest people. So we call that quintile 1, quintile 5, quintile 1 ratio. And what you see there is that overall, this ratio was 4.4 in Africa. So what does that mean? It means that health insurance coverage amongst people in the highest quintile is 4 times more than coverage amongst people in the lowest quintile. So essentially it tells you that most of health insurance enrollment and coverage within the African continent is really concentrated amongst the rich. Now, this varies quite a bit across African countries. The countries with the worst inequality was Nigeria, where people in the highest, in the highest socioeconomic quintile, so the richest, had about 350 times more level of coverage compared to those in the lowest quintile. So very, very high level of inequality. But again, we have outliers. So we have countries like Gabon, where in quintile 5, quintile 1 ratio is less than 1, which tells you that the poor have more coverage than the rich, right? So if the ratio is 1, it means you have equal coverage. If it's above 1, it means you have inequality. If it is below 1, it means you have more coverage amongst the poor. So Gabon is one of the outliers. Ghana, once again, should be commended. Ghana and Rwanda should be commended for running health insurance schemes that tend to generally be more equitable compared to what we see across other African countries. So Matt, I think, has shown this slide, so I'm not going to dwell on it. But essentially, this is, I've zoomed in on one of the panels that Matt had, looking at contributions of different sources of financing to total health expenditure. And what we see in low and middle income countries is that social health insurance, which is the one that's, I don't know what color that is, but it's the one that I have pointed to, is about 5%. On average, it contributes about 5% to total health expenditure, which tells you that social health insurance generally in low and middle income countries is not a very effective mobilizer of resources. It's not a very effective mobilizer of resources for the health sector. Voluntary health insurance is a yellow, the yellow part of the curve, which is even much lower than social health insurance. So in terms of level of coverage, we are saying that health insurance generally hasn't performed very well in African continents in terms of equality or inequalities. We've seen that health insurance is generally not very equitable within the African continent. And then in terms of social health insurance or health insurance in general as a mobilizer of resources for the health sector, again, we see that it doesn't do quite well. But we've seen that there are certain outliers. There will always be outliers or exceptions to the rule. So what are we saying? We are saying that if we were to give health insurance, and especially contributory health insurance, a report card for Africa, the report card would be that it's highly inequitable, mobilizes minimum revenues, has inefficiencies, adverse selection, and which also contributes to financial sustainability challenges. I know we've talked about outliers, but if we were to have candid discussions with our colleagues from the outliers, from Rwanda and Ghana, for instance, and in other countries, I'm sure they will talk about challenges with financial sustainability of their social insurance schemes. We also have inefficiencies because of the voluntary nature of health insurance across our settings, because a huge percentage or proportion of our population is informal. And essentially what you end up is a situation like the one we have in Kenya. I recognize that that plot is probably obscured, but essentially in Kenya what we did, so Kenya also has a national health insurance scheme, which I'm sure one of my colleagues will talk about in the afternoon. And when we did an analysis a while back to look at the loss ratio or the payout ratio in the amongst the formal sector and in the informal sector. So formal sector is mandatory because it's payroll taxes, compulsory contributions from payroll, while informal sector, while on paper is mandatory, in practice it's voluntary because of difficulties in enforcing mandatory contributions. And when we look at the loss ratio between these two schemes, what we find is that on average about 70% of contributions from the formal sector are used to pay out benefits, while about 300% of contributions from the informal sector are used to pay out benefits to the informal sector. So basically, for every dollar collected from the informal sector, $3 are used to pay for benefits, very unsustainable, while in the formal sector, for every dollar collected, about 70 cents are used to pay for benefits. So adverse selection is a big issue that compromises financial sustainability of social health insurance schemes. So it is because of some of these challenges and the experiences on the ground of how health insurance and specifically contributory health insurance works that this paper, some colleagues wrote this paper, which I recommend. I recommend as recommended reading to all of you, given that you're all clearly interested or shareholders or stakeholders in contributory health insurance in Africa. Paper around the seeming sort of keenness by low and middle income countries to implement contributory health insurance scheme, and commenting that is it perhaps an addiction to a bad idea. So it is something that we all need to reflect on even as we continue to implement our schemes. So I recognize that what I have painted looks like a very bleak picture of health insurance, but having said that, there are outliers across low and middle income countries. And you can use different parameters to judge what is considered an outlier. What I have used here is the extent to which countries have managed to achieve high levels of population coverage with health insurance in low and middle income countries. And there are several outliers. Within Africa, we have Rwanda and Ghana, of course, who've achieved higher levels of population coverage. And across Latin America and Asia, you also have several other countries. And these are countries that have managed to achieve high levels of health insurance despite having high levels of poverty and high levels of informality, similar to most other low and middle income countries, and certainly similar to African countries. So the question then is, within a context like this, what does it mean? What is it that countries that are similar to our countries are able to achieve these high levels of health insurance coverage against a context of informality and poverty? I think this is something that we all need to reflect on, especially if we are in countries that are actively implementing social health insurance schemes. Some of the things that emerge from the lessons that emerge from these countries is the fact that health insurance within these countries are essentially mandatory or compulsory. So health insurance in these countries are mandatory or compulsory as opposed to being voluntary. So that seems to be a distinct feature in these countries. But again, as countries, as we think about making our schemes mandatory or compulsory, we have to contend with our capacity to enforce. Some countries are clearly better at enforcing than others, but most countries really struggle with enforcing contributions from the voluntary sector. And this is what leads to the situation that I think Matt mentioned, which is the problem of the missing middle. So you have the informal sector that you're begging constantly to enroll and remain within health insurance schemes, but in practice they keep falling off or keep joining only because of adverse selection. So making our schemes mandatory or compulsory if we already have schemes. Substantial tax funding, I think, again, this has been spoken about. What we see across the countries that are exemplars in achieving high levels of health insurance coverage is that actually there is a high level of reliance on tax funding to finance these schemes as opposed to high level of reliance on premium contributions. So that seems to be one of the distinguishing features here. And just to take the example of our African exemplars, Ghana and Rwanda. In Ghana, the last time I looked at the data, it looked as though tax sources contributed to above 90%. But of course, I'm standing in front of the real people here. They can correct me or endorse it. But essentially, you have a scheme that is essentially a tax-funded scheme. And so it's important that people do not confuse and go around saying that Ghana has managed to achieve high levels of health insurance using a contributory scheme, while actually most of it is tax-funded. Similar to Rwanda, last time I looked at the data, it's about 51%. We have Regis there who can confirm or disapprove it, but essentially you have high levels of tax funding that are going into this scheme and making them a bit more effective at achieving high levels of coverage. The other thing that is distinct across these outliers or exemplars is the fact that some of them use an ideal approach, which is using a universal approach, so targeting everyone and seeking to get everyone covered using tax subsidies. So Thailand is a very good example that has a universal health coverage scheme that is tax funded. Some countries that are unable to do that for many reasons, some might be ideological and some might be fiscal constraints, have opted for targeting the poor. So targeting the people that need it the most within the population, starting with them, as opposed to starting with the people at the top. So your civil servants, your people in the formal sector and so on. Starting with them and providing subsidies to the people at this level. Several countries are doing that. Ghana, Rwanda definitely doing that. Countries like Peru and Argentina doing that as well. So providing subsidies for the poor, making it more equitable, making it more pro-poor, seems to be a strategy that exemplars or outliers in health insurance coverage in low and middle income countries are applying. So I started by saying these countries are outliers based on one criteria, which is level of population coverage with health insurance. Level of population coverage with health insurance. But that cannot be the only metric that we use to assess a financing scheme. We ought to use many other metrics. One is a primary objective of a health financing mechanism, which is to provide financial risk protection. So it is quite important that as we seek to expand population coverage, we remain cautious of this phenomenon known as coverage without financial risk protection. So it is quite possible to achieve high levels of population coverage with health insurance, but still struggle when it comes to financial risk protection. And again, across our outliers, we can see that we have some countries that have managed to achieve high levels. So the ones that are shaded green at the very end there. So this is Rwanda, Thailand, Colombia have managed to achieve high levels of population coverage and managed to reduce, or rather achieve low levels of out-of-pocket expenditure as a share of total health expenditure. But most of the other outliers, including Ghana, seems to be still struggling with out-of-pocket expenditure. So most of the outliers have high levels of population coverage with health insurance, but are struggling as much as the other countries when it comes to the share of out-of-pocket payments, or rather out-of-pocket payments as a share of total health expenditure. So that tells you that it is not enough to give a card to a household or an individual. You also have to think about how effective that card is in terms of providing financial risk protection. And there are many reasons why someone can have a health insurance card but still incur out-of-pocket expenditure. Very many reasons why that can happen, but part of it is really just thinking about once the funds have been mobilized. First, you have to think about, are the funds that are being mobilized sufficient to actually cover the costs of healthcare? And second, once the funds have been mobilized, how are you purchasing your healthcare services? Are you purchasing your healthcare services such that you're being responsive to the healthcare needs of the population? So thinking beyond just revenue mobilization and thinking about the purchasing function of these health insurance schemes is really quite important. So we've talked about these lessons. We've talked about the fact that it's important that these schemes are mandatory, but you have to think about how to enforce. It is important that they are tax financed, so thinking about allocating taxes to these schemes is quite important. It is important to try and be universal. If you have fiscal constraints, it's important to start with the poor, so ensuring that your scheme has subsidies for the poor seem to work in these outlier countries. And last but not least, strategic purchasing. So ensuring that you're making evidence-based decisions about the benefit package that you're covering or purchasing within these schemes. Ensuring that that benefit package is evidence-based, that evidence package is responsive to population health needs. It actually resonates with population health needs. And ensuring that the provider payment mechanisms, the provider payment rates are optimized so that you have adequate depth of coverage. You don't have your health insurance scheme covering only a small portion of out-of-pocket payments, leaving the population to still incur high levels of out-of-pocket payments. So these seem to be some of the lessons that emerge from the outliers in health insurance coverage. Thank you.
One more time, ladies and gentlemen, a round of applause. Mr. Edwin Barasa. A lot of you may be wondering, it looks like we've changed the program. We've not changed the program. As a matter of fact, the second presentation ties really well into this presentation that has just been delivered. We should have had preliminary findings of the lessons learned to date. But it's worthy of note that this presentation is part of the first part of work being done by the School of Public Health in distilling the lessons from our data analysis. So this has just been the first part, and our brother has been kind to give us the presentation. The second part will be coming shortly in the course of this program. We want to move into another very interesting theme, a success story, that's of the NHIS Ghana. Who better to do it for us than the CEO, ladies and gentlemen, the Honorable Dr. Bernard Okoboy.
Thank you very much, my brother. Because I didn't get the opportunity to make some remarks in the first part of the program, I'd like to quickly say I'm very grateful to all of you for coming to Accra for this conference. Let me also say a very big thank you to WHO, Professor Kasolo and the team for partnering the National Health Insurance to organize this particular conference. A brief background: I happened to participate in the Global Health Insurance Summit that was organized in Prague some 12 months ago. And immediately I got to the place, I started asking myself questions. Why do I have to come all the way from Accra to Prague when I've not met Africans discussing our issues locally? And that is where we started this conversation. In fact, initially we wanted to have the theme to be health insurance in Africa. And Professor Kasolo and WHO said, others are doing well, but not necessarily through the health insurance vehicle. So why not make it financing UHC? And I'm happy that largely, as far as I know, this is the first time that almost the whole continent is dedicating attention to learning experiences locally within the region. And we have to be proud of ourselves. Let me also thank the Ministry of Health in Ghana, our government. The President, His Excellency Nana Addo Dankwa Akufo-Addo, for all the support to make this possible. We are grateful to our board. We have almost half of the board fully seated right in front of me. They are marking what I'm doing here. So I'm being very careful. We are here to present our journey so far, 20 years of the National Health Insurance. I happen to be in South Korea, and it's amazing to read and to hear what they achieved within a short time after the Korean War in 1953. And what came out clearly is that you don't have to be rich to solve your primary health problems. You only need a good plan and a conversation. And I'm happy that we have a conversation here. I would allow, I'm the driver of the vehicle which has been on the road for 20 years. But I've only been driving for some 1 year and 6 months. I know passengers here who have sat in this vehicle for close to 20 years, to some of our staff. And so I'll let one of them, who is a very hard-working director, just like most of his colleagues, to do the detailed presentation. He will do it for 3 reasons. I'm a physician, but I'm also a politician. And when a politician tells a story, some will claim it's been amplified. So I'll let him tell the story. Secondly, I was made a chief recently up north in Ghana. And chiefs don't speak for long. And then thirdly, which is the most important point I want most of us to take home, those who do the real work, which is our staff, when it comes to the big platforms like this, the world must see them. And so on this occasion, I'd like to call Mr. Oti Frimpong, one of our very hard-working directors, to tell you our journey so far in 20 years. Thank you very much.
Thank you very much, Chief. Good afternoon to you all, and let me step in the earlier protocols. Like Chief rightly said, as we are sharing knowledge, we need to also look at our cultural practices where chiefs have to be allowing their linguists to speak. So, Chief, I'm very much grateful for the opportunity. Per the outline, we're going to look at the history of healthcare financing in Ghana. Then we'll look at the background of Ghana's NHIS, then the operations of the scheme, and then the adaptable lessons as we find ourselves here. So by way of statistics, Ghana's population as at the PHC, or Population and Housing Census, in 2021 stood at 30.8 million. And again, in Ghana, we have 16 regions. Traditionally, we're having 10 regions, and we added 6 more regions. So currently, we have 16 regions. The GDP per capita, per the World Bank report in 2021, stood at $2,445 US. And the life expectancy in Ghana is 64 years. By way of our Ghana Health Service sector, the governance is the Ministry of Health. And under the ministry, we have in the agencies which NHI find ourselves under the agencies of the ministry. And we have the Food and Drugs Authority. We also have the HIFRA. And per the service provision, we have in the Ghana Health Service, that is a major service provider in the country. Then we have the Christian Health Association of Ghana. We have the faith-based providers like the Ahmadiyya Muslim. We have the quasi-government facilities. These are predominant in most of our universities. And then we have the private facilities. Then the 3-tier health delivery system in Ghana is a primary level made up of the CHIPS, the health centers, the polyclinics, and then the district hospitals. And in the secondary, we're looking at the regional hospitals. For our colleagues who are not in Ghana, the CHIPS is the community health planning services. And then we have the tertiary, which is the teaching and specialist hospitals. This slide is really key because it gives us the health financing situation in Ghana. And since independence in 1957, we were financing healthcare delivery with a tax. So this went on and on till 1970. Everyone who accesses healthcare, we take it for free and we pay through the tax system. And at some point in time, we realized that there were other competing sectors that also needed some form of resources. Thank you very much. Thank you very much. There were other sectors of the economy that also needed some resources.
Just remove it and put
So we're not able to fund the medical care fully out of the meager taxes because we need to also address other sectors of the economy. So in the 70s to the 1983, we were charging members who actually access healthcare a token. And those who witnessed the 1983 crisis in Ghana, or you might have read about it, we went through a lot of economic hardships where there was serious drought in the country, food insecurity, and then famine. So at some point in time, we needed to drive certain things that will grow the economy. And so it was difficult for us to use our resources to fund the health sector. So there was that minimum token when you go to any of these facilities to access healthcare. So it's a trade right up to 1990. If you are not having funds, then it means that you cannot access healthcare. And locally, we term this as the cash and carry system. You need to pay before you access healthcare. And in the 90s to the 2003, we realized that these challenges persisted, and there was a need for us to think around it, how best we can support the citizenry in terms of accessing healthcare. So there was some form of community insurance in the country where some faith-based organizations have started some form of communal level of insurance. We can talk of the Nkranzes, the Okoman. And at the same time, the early part of 2000, when there was a lot of political heat in the economy in terms of what we have to do with regards to our health, the MPP government then provided the health insurance in their manifesto and said that they were going to implement when they come to power. Under the former president, John Agyekum Kufuor, when MPP assumed power in the year 2000, they tried as much as possible to implement what was in the manifesto. So in 2003, we passed the law mandating NHIS to being, and that is the Act 650 in 2003. Same vein, in the following year, they needed to regularize this act by passing on the legislative instrument, which is 1809 in September 2004. So health insurance came to being, and that is what has guaranteed some of us the jobs up to now. And that is where we working now. So in the initial stage, we had the social type of health insurance, and then we had the commercial type. The social was the district mutual health insurance schemes that were established across the country, and then we had about 145 districts practicing these district mutual health insurance schemes, and then we had the private ones too as well. So per few background, as I indicated, we had this district mutual health insurance schemes, and they were governed by the district board of governors because they were established as a company limited by guarantee, and they had their own set of board. And at some point in time, it was very difficult in terms of governance because in terms of recruitment, it's done at the district level, but payment and what have you has to come from the national. So there was a need for us to streamline this governance system, which brought it to a unitary kind of insurance in passing the law in 2012 to be Act 852. Again, we have a finance system mainly by the earmark funds from the Social Security and then the tax. And enrollment is mandatory in our system, as my earlier presenter said. We have an implicit benefit package that covers about 95% of the disease conditions in our country. And then providers are also contracted from public, private, and faith-based sectors to provide services to our members who have been enrolled. Membership stood at 55%, that is 17.2 million as at December 2022. The strategy this year, as a challenge put to us by our CEO and then the board, is to do 20 million because we're celebrating our 20th anniversary, and there are a lot of activities that we have to put in place to make sure we achieve this mark. So we are trying as much as possible to do the 20 million, which will translate into 62% of the population. And if we are to do a 3% incremental every year, we are likely to achieve the UAC by 2030. The background continues. We have 171 district offices and then the 16 regional offices. Per division, the divisions are 3. That is administration and HR, operations, finance. We have all the heads here. And the organization is headed by the CEO. And then we're having 17 directorates and departments in all. When you come to the key players in the NHI architecture, we have what we call the tripod. That is the purchaser, the subscriber or the member, the providers. And overall, we are being supervised by the ministry. That is the Ministry of Health. So NHIS as purchaser, we ensure that we register or enroll members, bring them on board, sign contract with our providers so that our members will be able to access healthcare. And whenever they access healthcare, they submit claims with VAT and then pay. So we ensure the providers also provide quality services to our subscribers or members. So Ghana's NHI journey to the UAC. Per the WHO definition, we have in 3 dimensions. And in the context of Ghana, NHIS, we look at the breadth, the depth, and then the height. In terms of the breadth, as I indicated earlier, we want to know who is insured, and we have done 55% as of December 2022. And the depth, in terms of the benefit package, we cover 95% of the disease burden. And what proportion of the cost is covered with the Ghana's benefit package? If you happen to enjoy any services within the benefit package, there is no co-payment or no top-up. It is 100% coverage under the benefit package. Membership. The object is to attain universal health care in relation to persons resident in the country and persons not resident in the country but who are on a visit to Ghana. That is official or permanent visit with all the necessary documentations. This is the registration at the district office. It has gone through a lot of changes, But we adopted these steps in 2013. From the onset, that is in 2005, we were having a lot of fragmented softwares and printing different ID cards. I'm happy Professor Irene is here. At some point in time, she was not so comfortable with the health facility attendant cards that were bombarding at her facilities. And this thing has actually changed. In 2006, we also adopted a magnetic ID card, which was more secure than the laminated cards that we used to have. But at a certain point in time, we were having challenges with the address system. We had a lot of cards sitting at the district offices, which we could not distribute. So management in 2013 came by the biometric system. Instantly when you enroll, you get your card and you leave the office. We don't keep the cards at our place. And these are the stages that you have to go through. The stage one is for the staff to interview you. And after the interview and education, they will be able to tell the category with which you belong to. Either you are in the paying category or non-paying. If you are paying, you make the payment. If you are in the non-paying, you go to stage 3 for your data to be captured. Then we also take your biometrics in terms of fingerprints. We take the photograph, and then we make sure you go through the data that we have captured to see if there are no errors. And then we print your ID card. We verify, authenticate the ID card, and then give it to you so that you can use to access healthcare. And whilst you are leaving the office, we also give you an information that is membership booklet that you have to use, which we have the frequently asked questions, the benefit package, and everything. At the latter stage, because we are trying as much as possible to innovate, we have tweaked the latter bit a bit because we are now using the Ghana card. So if you have the Ghana card and we capture your data and we generate your NHIS number, we don't go ahead printing a new card for you. In order to save costs, we link your NHIS number to the Ghana card and you can use the Ghana card to access healthcare. So we no more printing for those who have the Ghana card. But this made our offices very busy because we need to capture every person's data by data. So NHIS office then was one of the busiest offices in the country. So we brought up some innovations in the year 2018 where there was a need for us to do all the renewals because we've done a lot of registration. What is the technological platform that we can use to renew the membership? So we brought the Star 929, and at the comfort of your home, you can renew your membership. And we don't need any sophisticated phone, just any ordinary phone you can use to do the renewal. You can also check your policy expiry, the benefit package, medicines list, and then also, like I said earlier on, renew your membership. And this strives on the USSD. And there was no avenue for us to do a new registration. So management also felt that there's a lot to go in terms of digitalization. So last year, that was December 5th, we launched the new app. That is my NHIS app. With this app, you can download the app from any of your phones, that is Android phone or iPhone, and then you'll be able to enroll using the Ghana card, renew using the Ghana card. You can also link your NHIS to the Ghana card. Again, there is a possibility for you to enroll or renew for a third party. And we have also opened up a group registration portal too as well. There are a lot of modules in this app that when you open it up, it can even locate or give you the facility that you want to access and more other functionalities on this app. So that is the digital agenda of the management and the organization. In terms of active membership, like I said, we did 17.2, and those who are exempted from paying premium constitutes a chunk, and that is about 65.9%. The percentage that enrolled more was those under 18 years, followed by those in the adult informal sector. And this has been the membership coverage trend from 2013 to 2022. So it keeps increasing in terms of active membership, and then the population coverage too as well. Benefit package, NHIS have an extensive benefit package. We do the outpatient services, the inpatient services, the oral services, eye care, maternity services, and emergency cases. Then these are the exclusion lists. The rehabilitation other than physiotherapy, appliances and prostheses, except intraocular lenses, cosmetic surgeries, the HIV retroviral drugs, the VIP ward accommodation, the mortuary services, then the medical examination for visas, and then driving license. Some of these things we don't actually cover. And some of these programs are also run powered by the ministry. So if it is being run by the ministry for free, then we don't cover them. And these are the programs that is being run by the ministry. We have highlighted the family planning red background because we have started accepting some of the services on the benefit package. So in terms of provider payment systems, there has been a lot of reforms. When we started the full implementation in 2005, we're using the full fee for service for the services and then the medicines. That is itemized payment. And in 2008, we have to go into the Ghana diagnostic related groupings for some of the outpatient and then inpatient services. And that is what we are using till now in terms of services. But the medicine still remains itemized. That is fee for services. In 2012, we also piloted capitation for outpatient for the primary care, and is currently on hold. Claims management by the Act, we have also established for Claims Processing Center. Claims used to be processed at the various district offices, but we have pulled those capacities together under 4 centers. We have the Tamale, the Kumasi, Accra, and Cape Coast CPCs, and they are into the claims processing. On the average, we process was about 26 million claims, and we are doing 60.3 e-claim submission and vetting as at the end of 2022. And management ensure that with regards to claims submission and processing, we need to go fully electronic. So that conscious effort has yielded a very good results, and as we speak, we are into 90% claims electronic processing, and we're hoping by the close of the year, we'll be doing 100%. So this is the electronic versus manual. It's from 2018, because 2005, there was nothing like electronic. It was all manual. But we're looking at 2018 to 2022. If you look at the graph, 2021 to 2022, under the current administration, it tells you the conscious effort that we are putting in to make sure that we go fully electronic. In terms of quality assurance, credentials are granted to different providers, that is by ownership in terms of private, public, faith-based, and then the type, that is primary, secondary, tertiary. The new credentials that we give out is valid for 4 years, and then renew. If they come to renew, then we give them 2 years. And the credentialing are not transferable, and they are also location specific. Currently, we have developed an online portal for new applications, so we don't accept paper application. You need to apply online. So these are the facilities that we have credentialed and we are doing business with. I believe the pie chart will be key. If you look at the public facilities, we're doing almost 73%. The private complement a lot because it's next to the public institution, which we are doing 21%. Kwizai 1, and then the mission facilities 5%. We also do clinical and compliance audit because it's enshrined in the Act. The quality improvement process that seeks to improve patient care and outcomes. We also go to review claims that they have actually submitted before, and we make payment. We have to go and review, and if we see if there are any challenges on the payment that we did, we have to speak to them. Either we take some of the monies off or we advise them. And in all this, there are some tools that we try as much as possible to use to make our work smooth. And these are the NHIS Act, the NHIS Medicines List, the Standard Treatment Guidelines, the Essential Medicines List, and then the Pharmacy Act. In terms of financing arrangement, this is the revenue sources and its application. For the inflow, we have the earmark funds, that is the NHIL 2.5% of the consumption tax, and then the SNIT contributions 2.5%. That is Social Security and National Insurance Trust. From the formal sector workers, we take 2.5%. And the road accident fund, which is a bit minimal, and then the premium and registration fee, interest on investment, then from donor partners and other incomes. So the flow from the NHIL, it goes straight into the consolidated fund, that is the Ministry of Finance, but the other funds comes into the NHI fund. And the area of expenditure in terms of the outflow, very key, and where most of our funds goes to is the payment of healthcare providers, which we said earlier on that we are doing very well, because technically we are about a month or two old. Then we use the funds for administrative purposes and also support the ministry, that is the Ministry of Health. This is the funds that we give to them for most of the preventive services that they do in terms of immunizations and what have you. So these are the sources in terms of the component. So a lot is gotten from the mandatory taxes, that is from the tax consumption tax and then the SNIT, and we're getting about 92.76, which speaks to my earlier presenters' figures. Then we have the premium and processing fee, which is a bit minimal, almost 6%. Investment income is 1.3. What we are getting from our bilateral donors these days is very negligible. And then the other income is 0.08. So adaptable lessons that we hope that we'll pick as far as Ghana's NHIS is concerned, we have adopted bipartisan approach in all our dealings, because every government supports this health insurance. And there is that enabling legislation. We spoke about the Act, and then the innovative financing model. We operate a very extensive pro-poor exemption policy, and as I mentioned earlier on, about 65.7 of them are exempted from paying premiums. So this is highly funded by the government. We also go by the decentralized approach. Almost all our operations are decentralized with the district offices and then the regional as well as the CPCs across the country. The organization is technology-driven. Currently, we are not accepting, or we're not using this control or receipt books. We have what we call the electronic receipting system. And then our claims, as I indicated earlier, are also managed electronically, which we are 90% now. The game changers on our enrollment has been the mobile renewal and then the My NHIS app. We are avoiding paper works, because almost all our operations are paperless. And there's a lot of effective stakeholder engagement. And as we are having the international one, being the maiden, this is what we do best as an organization. And under the current administration, that is the board and the management, the direction that we go in is the 5Ds as we celebrate 20 years. That is 5D at 2D. And the 5Ds are the digitalization agenda, the development, where we're having the physical and human development. And we're grateful to World Health Organization. Yesterday, and then the previous day, that's 2 days, we had a pre-conference which has built a capacity of staff on health financing. We also try as much as possible to disseminate information. We have a lot of platforms, we have the call centers, and what have you to disseminate NHIS information. It's a data-driven organization because we want to take decisions based on data. And again, we also try as much as possible to decentralize all our operations from the head office to the districts and then the regions. On this note, I'm very much grateful for your attention. Thank you.
Such a beautiful story. Ladies and gentlemen, one more time, let's celebrate the NHIS and the NHIA. Shortly, we get to hear from our chairperson. Before that, however, the floor is open for some questions, contributions, suggestions. But let's take a little video and then we'll come back to you. If you're ready. While they're sorting out the video, the floor is now open for interaction. Please raise your hand, identify yourself, and you can shoot straight to your question, your suggestion. You can direct them to any of the presenters thus far. And on we shall go. Yes, sir. You have a mic on your table. Please press it.
Je m'appelle Dr Mamadou Selili.
I shall ask all our friends who are not bilingual to please use their translation devices. Thank you very much. For English, 1. For French, 2. Mon ami, on continue.
Merci beaucoup. Donc, je m'appelle Mamadou Selili, docteur Mamadou Selili, je suis du Sénégal, de l'Agence sénégalaise de la couverture maladie universelle. C'est une contribution qui porte sur les indicateurs de protection financière.
Please hold on 1 minute. Translator 1 seems to have some feedback. Can you all hear 1, English? Can we please rectify 1, English? Okay, please try again.
Ok. Donc, docteur Mamadou Selili de l'Agence sénégalaise de la couverture maladie universelle. Ma question porte sur la présentation du docteur Mathieu Joët de l'OMS et sur l'indicateur de protection financière. Il a souligné, et c'est quelque chose qui revient assez souvent dans la littérature, qu'il y a quelquefois une contradiction entre ce que cet indicateur montre et d'autres éléments, notamment ce que les États mettent comme ressources. Est-ce qu'il n'y a pas lieu de se dire que cet indicateur devrait être revu, surtout dans le contexte africain? Parce que quand on veut mesurer la protection financière en s'appuyant essentiellement sur les dépenses catastrophiques, il y a une forte réalité qui est aujourd'hui masquée. Je vois que l'OMS, depuis 2019, et même dans le rapport de 2021-2023, tente d'intégrer beaucoup plus la dimension
The mic, please.
Merci beaucoup. Donc je disais, dans les derniers rapports sur le suivi de la protection financière, il y a une plus grande intégration entre les dépenses catastrophiques de santé et les dépenses appauvrissantes, afin de tenir beaucoup plus compte des personnes pauvres. Mais dans nos pays où, par exemple, dans les pays de l'UEMOA où on a des taux de pauvreté de 40%, si on ne tient pas compte de ces populations-là dans les dépenses catastrophiques, si on ne se dit pas que les personnes pauvres qui utilisent des soins, même pour un minimum, ces personnes-là sont exposées à des dépenses catastrophiques. Considérer simplement qu'une dépense elle est catastrophique parce que c'est 10% du niveau de consommation globale, si on s'en tient à ça, on perd une grande information. Donc est-ce qu'il ne faudrait peut-être pas maintenant s'éloigner un peu de ce mode de mesure des dépenses catastrophiques et aller vers autre chose qui tient beaucoup plus compte des pauvres, en se disant qu'un pauvre, quelqu'un qui est déjà en dessous du seuil de pauvreté, qui n'arrive pas à réunir le minimum de ressources pour couvrir ses autres dépenses, cette personne-là, si elle engage des dépenses de santé, quel que soit le niveau, c'est une personne qui encourt des dépenses catastrophiques. Et peut-être c'est sur ça qu'il faut travailler pour réellement tenir compte du niveau de protection financière. Voilà ce que je voulais faire comme observation et question également. Merci.
Sincerely, we must apologize for the mix-up. I'm told English is now 0-0. And French is what? French is 1? Okay. So for those of you who did not understand, please, it just means that you must learn French. It's as simple as that. Can we have somebody translate briefly in English before we proceed to the next? You can? Okay. All right.
But let me verify. Thank you for. If I understand your question, it was about the measurement of catastrophic, and if someone's below the poverty line, even to spend 1 cent. Yeah, exactly. Yeah, no, I think it's a good point. You know, there's a lot of debate on the methodologies. There's a lot of discussion, arguments, debates on these measurements of financial protection. There is one alternative methodology which would actually, I think it's what you're suggesting, that if you're below the poverty line, you even spend 1 cent, right? And it qualifies as catastrophic. You don't have to reach 10% or 20%. Yeah, and so I think part of the challenge is when you go to the UN level and the global level, there's a lot of compromises that are made, and it's really difficult to change it. But it doesn't mean we can't measure it anyway, right? Even if it's not the official SDG indicator. But it's a very good point. I think it's a very valid one. And some colleagues in our regional office, they take this approach. Similarly, I mean, you have it a little bit more with the impoverishment, because the idea of impoverishment is a little bit simplistic, that you have to cross this poverty line to be counted. But if you're already below it, right, and then there is this additional measure of further impoverishment. So these are not perfect. They're indicators, right? I mean, that's, I suppose, if we think about what the word indicators mean, we just hope that they're accurate. But yeah, it's a good point, yeah.
Thank you very much for coming to my rescue. So we shall take the next. Please, 0-0 for English, and then 1 for French.
Yeah, thank you so much, and thank you for all the presentation. Maybe my question goes to the NHA. I think it's National Health Insurance Scheme for Ghana, who just presented. And actually, I'm interested to know of the 10% of disease conditions that have not been included into the scheme. What are the real issues? Why were they taken off? And maybe what is the way forward so that those issues are addressed? Thank you so much.
Doc, if it pleases you, can we take 3 more and then we shall revert? Okay. So there's a hand here, there's a hand here, there's a hand here. To be fair, let me take 1 from here and I'll take 2 from here, please.
Merci. Ma question s'adresse au professeur, l'intervenant numéro 2. Effectivement, quand il a fait sa présentation, il a montré les taux de couverture et il expliquait que le Ghana et le Rwanda étaient au-dessus de 50%. Je voudrais être sûr qu'il parlait bien de 2021, parce que si c'est 2021, j'avais fait une publication avec un collègue de l'OMS sur l'assurance maladie au Gabon qui montrait qu'on était déjà au-dessus de 60%. Je lui passerai donc cette publication-là pour qu'il en tienne compte. J'ai compris que très souvent, les publications francophones sont très peu prises en compte, mais il y a effectivement qui lui permettrait d'enrichir cela. Ma deuxième question s'adresse aux collègues du NHIS du Ghana. Le Ghana qui a une longue expérience, et je m'appuie sur l'expérience du Gabon où ça fait effectivement 13 ans, on constate sur un certain nombre de pays, en tout cas les pays francophones, plus l'assurance maladie monte en puissance, plus le ministère des Finances et le ministère de la Santé ont tendance à réduire leur budget. Et ça fait qu'il n'y a pas un gain qualitatif parce que finalement on se retrouve au même niveau de dépenses. Parce que comme il s'agit des taxes, le ministère des Finances et le ministère ont tendance à baisser cette dépense. Est-ce que c'est une même constatation qui est faite au Ghana Ou est-ce qu'au Ghana, vous avez réussi à faire en sorte que le ministère de la Santé maintienne son niveau de dépenses en tant que prestataire et les financements de l'assurance maladie deviennent comme des financements additionnels qui permettent véritablement d'améliorer la qualité de soins? Voilà ma question. Merci.
All I heard was croissant and vin.
Thank you so much, colleagues. My name is Christabel Avewe. I work with the WHO in Uganda. My question goes to the NHIF colleague. He mentioned that the poor are exempted from making any contribution to the scheme. So I just wanted to know how they are identified and how that list keeps evolving, because the demographic, the proportion of the demographic that's poor keeps changing, either going into poverty or coming out of poverty. So how is that frequently updated and on what basis? My second question is about, I saw that partners are also contributing money to the NHIF. I just wanted to know what the magnitude of that money is in terms of just a proportion of the total amount that the NHIF receives, and how that compares with the rest of the partner contribution that goes off budget, because in most countries we see that the biggest cause of fragmentation is external aid that is routed out of the government PFM system. The third question is on what's, sorry, I have just 3 questions. What's driving the high out-of-pocket expenditure, the 30%? If we could just get a sense of what the drivers are, given that you're making good progress on the coverage side, why do we still see a high burden of catastrophic expenditure? Thank you.
Thank you. The last one for this round will go to my colleague from the Federal Republic of Nigeria, Oga. How now?
Thank you very much. My name is Dr. Francis Ukwija. I work for the WHO in Nigeria. And I want to thank the colleagues who made the presentation. So first, I'll go to my colleague Math, and I'm Professor Edwin Barasa. Both of them spoke to the addiction to the bad habit. And that is what many countries in Africa are doing in terms of embracing and expanding coverage on health insurance, in terms of contributory health insurance. From the evidences provided, it looks like moving to tax-based financing is the most appropriate method or approach. Now, it happens that there are countries already that are already mainstreamed within this contributory schemes. Can you share some good practices of countries that are predominantly contributory that are moving towards predominantly tax-based financing? What are they doing? Because it looks to me that it's going to be a very tough political decision to take. That's number one. The second question again is to our colleagues from the NHIS. They presented a very beautiful story of what's going on, and indeed many of our countries are looking up to the Ghana NHIS. And quite recently we sent over some of our colleagues from the state health insurance schemes in Anambra State to come and understudy what is going on in Ghana. Is it possible for you to identify about 3 key challenges? Because I don't think that is presented. So that countries that are here can also know what main challenges you have in driving coverage of the population through health insurance in Ghana. Thank you very much.
Okay. Professor Barasa, Dr. Matthew, and Dr. Okoboy, you stand accused. Who will begin?
Thank you. So I had 3 questions. Unfortunately, I didn't get the French one, so unless it is going to be repeated, I'm going to address the ones that I was able to hear. One, I think, came from Christabel around why we have 30% out-of-pocket payments in in Ghana, given that we have high levels of coverage with health insurance. So I can attempt to answer that, and then the NHIS can also provide an answer to that. I mean, there are many reasons why that would happen. A very clear one is the fact that whenever we look at out-of-pocket contribution to total health expenditure, we are looking at its total health expenditure, so it's essentially the entire population, okay? Ghana does not have 100% health insurance coverage, which means that we still have a proportion of the population that is not covered and therefore pays out of pocket. In the estimates I provided, which came from the last Ghana census, enrollment was about 69%, but then if you disaggregate it and look at the ones that are actively enrolled, and I think that is what was presented by the NHIS, it's a bit lower than that. I think the presentation was 50-something%. So you have a substantial part of the population that still pays out of pocket because it's not covered, amongst other reasons. There was a question from the colleague from Nigeria around sort of lessons or examples of countries that have social health insurance schemes but are moving towards tax financing. So there are several, countries that are indeed doing that. I mean, we are currently being hosted by one of those countries. We have an NHIS that still has contributions, but relies substantially from tax allocation to their NHIS. I gave the example of Rwanda, where 50% roughly comes from taxes. And my home country, Kenya. So Kenya has a national health insurance fund that for a very long time has been and continues to be predominantly reliant on contributory financing. But we now have a new bill in Parliament that retains the contributory nature, but introduces substantial tax allocation to the scheme. So we have examples of countries moving towards tax financing.
Thanks. Thank you, Francis. I think the message that both Edwin and myself have given this morning is even countries with SHI schemes are still predominantly tax financed, right? And I think that's something that is really important to recognize. And if you want, I mean, where Ghana is now 56%, if you look historically at countries, and Thailand's always a good one to jump on, the Philippines is a similar one, that you get stuck at a certain level, right? And the only way to kind of get towards 80, 90, 100 is through subsidies. It's pretty much a fact. The other sort of, I think, assumption that has been made in, certainly in Asia in the 2000s, was that, like what happened post-war, is that as countries grew economically, people would naturally flow into salaried occupation, and then they could just be captured through the tax system. That hasn't happened. If you look in Asia, rapid economic growth through the 2000s, you actually saw an increase in informality, bizarrely. So that relationship doesn't hold anymore. So it gets a little bit complicated. But I think just a final point, I think given that even countries, Ghana's a little bit different, but it's still to some extent true, with SHI or thinking about it, are still going to need to rely predominantly on tax financing. Why do it? Let me put it out there, right? Why really do it? I think Zambia is a really nice example. If you look between 2000 and 2020, and I think health insurance was launched in 2020, right? They massively improved financial protection. It's close to zero now. The service coverage index, I'm giving a shout out to Zambia now, is I think 56. Ghana, it's actually 48, right? I mean, I think this is just intellectually interesting. Now, there's something in the, so maybe something's going on better in Zambia that we also need, and it's not, but I think the thing that's actually missing from all this is actually quality of care. And when you see a lot of what you offer here, I think driving up quality care is something we're not measuring or really capturing very well, and maybe there's something there we need to understand a lot better. So.
Thank you very much. I think there was a question on the budget. I think a participant said in their country as they enroll more people. The Ministry of Health cuts back their budget. So in Ghana, like we said, the taxes fund about 90% of the insurance. And by law, these taxes must go to the Ministry of Finance before they are released to the fund, the National Health Insurance Fund. Over the past 20 years or so, the challenge, so when it comes to challenges, one of the challenges that you don't get the full complement of what goes to the Ministry of Finance. So if you collect, let's say, $400 million, sometimes you can get about $300 million, and the rest supports other sectors in terms of budgetary allocation. So based on which finance minister is at the place, you might get a higher percentage of what has been collected or a lower one. So the Ministry of Health in Ghana really don't determine what comes to us. Largely, it is the Ministry of Finance. But in preparing our budget as an agency, because the Ministry of Health is our mother sector, we do it with them, with their supervision. So that is, I think largely there's still ongoing conversation on how to reduce discretion when it comes to the release of the funds. The law says all should come, but the law is not too strong. So maybe we have to, going forward, we'll look at ways to make the law quite strong. The exemption for the poor. So this is what happens. Every Ghanaian who registers onto the insurance scheme pays usually a processing fee. There are few people who are exempted. Children below 5 years don't pay any processing fees. But if you are an adult, you pay a processing fee of about 70 cents for the whole year to be registered onto the scheme. If you are a formal worker, you contribute to pension scheme, you pay only processing fee, which is 70 cents for the whole year. So that is the kind of charges we are talking about. So they are more or less, I don't know whether to say token or procedural. But those who are in the informal sector have to pay a premium. And guess what? Their premium is $1.70 for the whole year. So it's not a real premium. So largely, it is still the taxes that pay for the health care. And the exemptions we are talking about are those who have been categorized as indigents or so poor that they cannot afford even a cent. Those ones are usually captured by our Ministry for Gender and Social Welfare. So we have a ministry that looks at social classes and all that. So we work closely with them so that we onboard all those in that category. And their budget is handled directly by the government or through partners, donor partners. So those are the exemptions we are talking about. And that is the explanation. My brother from Gabon, although your question was not directed at me, it's good we use the 2021 figure so that we stay at second to Rwanda. So next year we'll use the more than current one, because once you cross 60, you come before us. That's on a lighter note. You know. Now someone asked about the 30% out of pocket for Ghana. So like Doc said, we have covered about 55% of the population. So we still have some who are with either private health insurance or pay out of pocket. I suspect the figure is quite high because in the big cities in Ghana, although some people are covered by the health insurance, historically, because purchasing power is high in the cities, you have a situation where some providers still take fees for services covered by the insurance. And so when you talk to a cross-section of the public, you are likely to meet people who tell you we pay out of pocket. Although the health insurance coverage is high, what is on the ground might reflect something not commensurate to the insurance coverage. Outside the big cities, 90 to 95% of all those who visit hospitals are fully covered by the health insurance. But when you come to the big cities, you have this more practice. We are working hard to reduce that practice. where people are covered by health insurance, but you have them paying for services. What is interesting also is that I have found myself in a public hospital in Accra, consulting on the side, and someone who is covered by the insurance tells me, "Doc, I know you are giving me all these medicines for free, but if you really have some drugs which will work very well, I'm ready to pay." So psychologically, people think it can't be true or real that all these medicines, the person has come with hypertension, diabetes, and pneumonia, and all are free, 4 or 5 drugs. So they want to pay, and I tell them this is okay. And so these are all cultural things that we have to deal with. Our challenges. Yes, we have challenges. The release of all the monies collected in our name is the first challenge. If all should come, the story would always be nicer. So that is one challenge. I think another challenge also is that as we speak, we pay an average of about $10 million every 30 days in the name of bills that are coming to us. And the bills only get bigger with time. So the question is that, is this the road to travel? Or we have to find other payment systems like the capitation, which we piloted some years ago, or what others are doing. So this is a very big challenge. Another challenge which I'll mention is the inefficiency when it comes to the claims process. We are trying to work on that with the digitalization of the whole process. But we are pushing ourselves further to make sure that every client or bill which is brought to us is biometrically verified as having been physically present at the hospital and having received the care. Because historically we've had cases prosecuted in court where hospitals submitted bills for people who are either not in the world or were not at the hospital. And these prosecutions ended up in jail terms. So until we have real in-time biometric validation, we can't really tell whether this $10 million is for people who are visiting hospitals. So that's another challenge. And then lastly, many people are not on this insurance scheme, not because they cannot afford the 70 cents or $1.70 a year. The only reason is that either they don't care, they don't have confidence, or they are waiting to get sick. So there are many people who only ask about insurance when they are not well. And that is why in our scheme, most of the time the staff are out there in the public, in the markets, on the streets, trying to rope them in. And I believe that with education, people will appreciate that you have to register and get on a scheme and not to wait until you are not well. Thank you very much.
I hope all the questions have been answered. But this is where we take a break, because when we come back, there'll be a lot more time for questions and contributions. Now, in bringing this session to a close, it's my pleasure to invite our chairperson to render his thoughts. Ladies and gentlemen, Professor Yao Edugyenfi. For all he has done for universal health coverage, I believe a deserving round of applause is in order. Prof, we are all yours. Shall I get you a stand?
No, I think it's okay. We'll manage. Good afternoon. Apparently, a protocol has been established, and with your permission, I'll stand on that. I thought I would be speaking before this session started, but it didn't turn out to be that way. But a lot of what I may have to say have been reflected already, so it will be like reminding of some of the nuggets that have been given to you already. I also take this opportunity to congratulate the Ghana Health Insurance Scheme for the 20th anniversary. It's like congratulating myself, though. You've done very well from bringing cash and carry through mutual health insurance to the level that we are at now, that we are considered worthy of emulation. Well done. The theme for the conference, Overcoming Financial Barriers and Providing Financial Risk Protection, as reflected in all the foregoing presentations, suggests to me that this meeting is about finding innovative and sustainable ways to finance universal health coverage and ensure health security. As I gather, this is the first time this is being held, such a conference is being held in the WHO designated sub-region of Africa, meaning maybe sub-Saharan Africa. I believe that North Africans don't consider themselves as part of WHO Africa anymore. Maybe they will be persuaded to come back someday. And I hope this will not be the last time. From the little I've gathered, it would appear that we will need to do this on a regular basis, because I think as we evolve, there is a need for more regular consultation amongst ourselves. I also surmise from the collaborative efforts of the organizing team, consisting of the Ministry of Health of Ghana and its agency, the NHIA, and the World Health Organization, that new and enhanced strategies are required if the WHO target of 2030 set for achieving universal health coverage and security is to be met on time. Let me take us back that United Nations in 2015 pronounced the target date for achieving universal health coverage as 2030, thereby allowing only 15 years for our developing economies to attain this impossible goal. As part of the Sustainable Development Goals, particularly SDG 3, Target 3.8, which states as such, universal health coverage including financial risk protection, access to quality essential health care must be achieved by 2030. But Target 338 of the Sustainable Development Goals seems to touch on the number one goal, no poverty. Health is wealth, and wealth means health. This no poverty thing mandates ending poverty in all its forms everywhere, providing services and access to safe, effective, quality, and affordable essential medicines and vaccines for all. In some countries, and maybe I believe even here, the major cost of our insurance bill are the medicines. Vaccines, from our history of what happened to us in COVID, a fully vaccinated person, I think it was going to cost us anywhere between $11 to $25 per person. That can cripple a whole economy. But we survived all that. But then it's incorporated there, and we are having to work towards achieving that. In fact, all the 17 Sustainable Development Goals and their 169 targets have implications directly or indirectly for health. Ladies and gentlemen, I repeat the definition. Universal health coverage has been defined as a situation where the whole population of a country has access to good quality core health services according to needs, preferences, regardless of income level, social status, or residency. It may be financed through tax or through contributory insurance schemes and organized through one national or a number of different schemes. These have been alluded to and explained, and the professor from WHO in his presentation expatiated on this. And to achieve this coverage of healthcare, the sources, levels, and management of finance need to be well designed to ensure sustainability. Ladies and gentlemen, it appears that there are two major pathways to achieve the goal of sustainability for health, universal healthcare coverage by most developed and developing countries such as ours. One is through compulsory and social insurance, which originally was known as the Bismarck model. I stand be corrected. Here, I think the historian will tell Bismarck, this was in the 18th century, when he was seeking to unite Germany, and he succeeded. And then, when the industrial explosion occurred and the economy was developing, he got caught a bit in a bit of economic downturn. And that's when he started introducing pensions and insurance schemes and all that. And as part of that, he introduced health insurance, and it took centuries, or let's say decades, for Germany to achieve health insurance, full coverage for health insurance. The other is through taxation, and that's the Beveridge model. And Lord Beveridge in 1947 introduced NHIS, and at that time it was supposed to cost about 70 million, and that's a lot of money at that time. And I believe in 1948, Parliament had to be called into emergency session to review. Maybe you may correct me. Correct, okay. So I dare say you are the experts and know the merits and demerits of all these things, and you will explore new ways within context of our developing economies for application and modification. Most developed and developing countries have used one or the other of the two models, or a mix, as Singapore did and as maybe Ghana we have done. Most of the countries of our sub-region are different levels of development as regards their economic status, labor markets, job opportunities, and healthcare systems. The question to ask is, are the healthcare financing systems insurance-based or tax-based or a mix, and how sustainable are these systems? And I'm sure that you will examine all such questions, as well as implications of our individual experiences, provide valuable lessons that other developing countries wishing to develop universal health coverage policy may learn from. And I believe the presentations so far are providing some of the answers. And I wish you will continue, and I hope we will have maybe some session, like plenary sessions, that will delve further into what we are putting out there. Many developing countries share common challenges in achieving universal health coverage. These are mainly due to unfavorable economic, political, and social factors that could become and have become major obstacles to progress. And I'm sure all these obstacles to progress towards UHC would be thoroughly examined during these plenary sessions, and common beneficial solutions provided. This may include the capitation, which has been alluded to both in funds and in the practice as regards to promotion, preventive, and curative. In all this, we must bear in mind that the more developed our economies become, the easier it is to overcome financial barriers and provide financial risk protection to achieve, sustain, and maintain universal health coverage. Japan was the first country in Asia to introduce health insurance system in 1920 as part of its social security systems development, and achieved UHC only recently. Japan's achievement paralleled the developments in its economic fortunes and successes. Korea has been referred to this morning, achieved universal coverage 12 years after implementing its social insurance program. The rapid economic growth allowed Korea to expand employment, job opportunities that inured to the success of the program. The economic boom allowed rapid expansion of the insurance coverage. Taiwan achieved universal health insurance in 1992, following a 6-year planning period, and achieved 98% population coverage in 1 year. Major contributing factors were strong political will, stable and healthy economy that could absorb additional increases in healthcare expenditure with existing health resources, that is, infrastructure and financial and human resource. At this juncture, I would say that, again, Ghana Health Insurance is not doing too bad. I think collaboratively with the ministry and government, there is Agenda 111. Collaboratively as well, the college, Ghana College of Physicians and Surgeons, is also accelerating and decentralizing its training that will also buttress this effort. Ladies and gentlemen, from lessons learned from various countries in our own country, it appears that there is no single formula or model to achieve universal health coverage. Each country needs to consider various factors determining its economic, political, and social status and apply the most suitable and feasible option to ensure them or to enable them to overcome financial barriers and provide financial risk protection. Ladies and gentlemen, let me conclude by urging us all, as we go through various plenary sessions or question and answer sessions, to review our systems, share our challenges and experiences, pool the information for further analysis to inform innovative financing strategies for adoption and to accelerate and sustain our advancement towards universal health coverage for our countries in the South region. I thank you, and I wish you bon appetit for the lunch to come. Thank you.
One more time, ladies and gentlemen, a round of applause for Professor Yawedu Gyamfi, our chairperson for this plenary. For the next few minutes, please lend your attention to the screen for a message from our title sponsor, Margins Group.
Imagine a world without worry. A place where everyone is who they say they are, where the people and assets most important to you are protected. A safe space, accessible only by the ones you authorize. A place of trust, transparency, and accountability. For over 3 decades, Margins ID Group and its subsidiaries have been building this world. Our state-of-the-art access control systems ensure by face, fingerprints, and even iris. Our asset tagging systems and CCTV installations ensure that the assets most important to you are exactly where you want them to be. We have conceptualized, designed, and built award-winning national identity infrastructures. The Ghana Card, in use by tens of millions of Ghanaians across the globe as their most trusted identity document. The non-citizen Ghana Card, in use by hundreds of thousands of non-citizens living in Ghana. Supported by our ultra-modern in-house designed and built verification system, currently in use by all financial institutions and multiple government and private agencies across the country. We are the identity experts for all things that represent you, your brand, call cards, product labels, smart labels, bank and loyalty cards. We represent you, and we are certified to do so by the International Organization for Standardization, ISO 9000-2015, ISO 20000-2018, ISO 27001-2013, and ISO 22301-2019. we are certified by Europay, MasterCard, and Visa, and proudly the only African facility to be certified by Intergraph at central banking level. Margins ID Group, made in Ghana by Ghanaians for the world. Visit us now at www.marginsgroup.com and use the contact tab to book your free consultation today. That's www.marginsgroup.com.
And thus 30 years plus of being the standard in the provision of identity, digitalization, and secure access solutions. Please, the Margins Group, they are yours for the applause. We also acknowledge with gratitude the immense contribution of our sponsors, Roche, Spectrum, Nationwide Medical Insurance, the National Insurance Commission, Apex Health Insurance, Metropolitan Health Insurance, BAC, JPPL, IPMC, UNFPA, CalBank, Republic Bank, Zoom Lion, FNB Bank, the Foreign Commonwealth and Development Office, OSD, Omnibank, DocuPro. Ladies and gentlemen, a round of applause for all our sponsors and our partners. But ladies and gentlemen, they join us as organizers, but also as sponsors. The WHO, a round of applause for them too. Shortly, we shall be proceeding to lunch. I want to encourage all the countries that have not submitted their presentations to please do so before lunch so that we'll have all of them lined up. When we come back, we will go into full details of the various countries represented, highlighting their core challenges, linkages, and lessons of experience on health financing in achieving UHC and health security. So on UHC financing, let me ask, how many are in favor of tax? Increased tax? How many are in favor of out-of-pocket? And how many are in favor of subsidies? Okay. I once cornered President Robert Mugabe in 2017, and I asked him a very interesting question. Between a wife who is very pretty and a wife who knows how to cook, which will he choose? Matthew, let me ask you the same question. Which will you choose? What will it be?
Oh, that's a tough one. All I can say is my wife doesn't cook very well, but we've been married 27 years, so there you go.
Please delete that. It shouldn't come in the video. President Robert Mugabe looked at me and said, "Young man, that's a very stupid question. In Africa, beauty doesn't last, but hunger can last forever." So since I don't want yours to tarry forever, ladies and gentlemen, we've designed a very simple way of going out. All those who have the red tags, all those who have the red bands, you'll be led out first, and then later those with the white will also be led out. So a round of applause for all our friends with the red tags. Thank you very much. We're coming back in exactly 1 hour. All latecomers will be punished.
Welcome to my NHIS mobile application demonstration. Hope you enjoy this tutorial. Let's begin. 1. Go to Apple App Store or Google Play Store on your smartphone. 2. Search for My NHIS app on App Stores. 3. Download and install the My NHIS app on your phone. 4. Look for My NHIS app logo on your smartphone screen. How to sign up and create an account on the My NHIS app. Tap on the My NHIS app logo to open the app. Welcome to the NHIS app. Log in if you already have an account on the app. Click Don't have an account